Hello, everybody. I'm honored and pleased to give a small lecture about well, treatment options for patients with bilateral vestibular loss or more issues. So let's start right away. So it's about optimizing, facilitate vestibular rehab at the first start of various vestibular disorders. Think about bilateral vestibular loss, unilateral vestibular loss, triple PD, whatever. So the traditional way of doing that is with rehab, like Klaus-Jan clearly pointed out. It's the first choice. You start to do that. There are the various elements that he pointed out that you have to incorporate. One of the big problems is, of course, adherence, because people say, yes, I do it, but in reality, they don't do it. And that's why it works generally better if you do it in combination with the physiotherapy, who is really checking out if everything works fine. Hello. Ladies and gentlemen, I'm not so happy with this approach. Is this recorded? You enjoy it many times. And generally, I think people that are in this field agree that it's very important to personalize the rehab approach. One should fix everybody. It's really that you can tailor it to the patient and also the specific pathology. And gamification is generally very effective. If you make some kind of challenge in it, then people can even addicted to that. And we have quite some experience with that with stroke patients with a special device that we developed with Maastricht University Eindhoven many years ago. And people were just doing that rehab all the time. Make more points, it works really good. There are, however, all kinds of things that have been developed in the past to improve the rehab and to give some kind of feedback to the patients so that they can do these challenges, whether it is in a game form or whatever. So you see here a number of them: electrotactile feedback via the tone, auditory visual, vibratory feedback, visual feedback, vibrotactile feedback for training specifically, and vibrotactile prosthesis ambulatory, like we do with the bounce back. So the first I want to mention is the BrainPort system that was developed many years ago based on the research of Bagherita, who was trying to find an entry port to give extra sensory information for people that had all kinds of handicaps. And it started with blind people who wanted to give some feedback to these patients so that they can move freely in the environment. And he came up with the idea of the electrotactile stimulation. So you have 100 points of an electrodes on the tongue, so you wear that. And there is a motion sensor also on the tongue. And then there is a device with a computer that controls everything and that you wear around your neck. So if you make a movement to the right and to the left, you feel a tingling sensation on your tongue that changes from orientation on your tongue. So you feel basically your movement, postural movements, based on this tingling sensation. That works pretty well. So you find out that people can use that feedback to improve their postural control. But it's not very practical, of course. You cannot wear it all the time and say, hello, how are you? Something like that. So that is a problem. And the idea was, of course, to use it for training. And then afterwards, it was tapped as something that you have learned and that it improved posture even if you take it away. And that was exactly what didn't happen so much. So you could improve training, improve performance, but when you take it out, finished. So that was the end, basically, of the BrainPort. Then other people, like John Allen, famous researcher from Basel, did a lot of research about posture control. And one of the developments that he did was trying to find out, is it possible to use feedback, sensory feedback, to improve training of posture control for these kind of patients that we're talking about. So one thing was hearing. So he loudspeakers around the patient. So you hear whether you move to the right or to the left, etc. And again, he could improve postural control in patients who were suffering from bilateral vascular loss, for example. But again, this is not very practical. You're not always walking in a room with loudspeakers. So he made a step forward, and that was the Sway Star, a very ingenious equipment that you wear. It's a quite bulky thing on your back and incorporating a lot of intelligence, providing vibrotactile stimulation to the head or tactors, spinning to the right and to the left, forward, backwards. A small light that warns you are at risk to fall, and also auditory information. So all kinds of sensory inputs to your brain to help to control posture. And inside this device here were gyroscopes that precisely detect the trunk movements forward, backwards, and forward. And indeed, he could show that the patients have a better control. So here you see the pitch velocity, eyes open. There's hardly any difference between patients with or without feedback. But when the eyes are closing, you see that patients bilateral without feedback, they have a lot of instability, which is decreasing when they have feedback. And here you see the healthy control. So that holds for the pitch and the role play. So this paper tells you that indeed he could, with different types of inputs, he could improve balance control while training. He did other studies also with triple PD. And at the end, the story is that again, he could improve balance control. He could speed up rehab, but the effect is very fast disappearing when you take away the feedback. Another way to do things is using all kinds of devices to measure the postural sway, like John Allen did, scopes, or you can use a platform that you're standing on that measure the pressures and measure your body sway. Or you can put sensors that are connected to the body, measuring again the postural movements. And this information can be used simply by visualizing, so put it on the screen how you are moving, and asking the patient to control that movement. So visual feedback that is used to improve your body control. One example is here, that is a very simple approach. So you have a small laser that you can see that is fixed in a small belt around your body. So this is a poor man's solution with a simple laser beam where you can see how you move and you can learn to control it from one place to another place. So you can use the platform, you can use a sensor on your body, or you can use this kind of devices. It's all the same principle. You have visual feedback of your movement, and you can use that to learn, to control, to do certain kind of movements and to train it. All about rehab. Very simple, elegant solution this. There are more complicated devices that you can see here. So the device that we developed about 30 years ago in Maastricht, when there were no simple machines that could do that. And you had the E2 test, the PairTech systems, which are dynamic postural control systems that are measuring the body sway and use that as an input to the computer to control visual stimuli in front of it. That can be the whole screen that is moving, or it can be virtual reality, whatever technology is used. The most advanced system is something that we have in Maastricht also. That is the Karen Extended, where people are standing on a big platform and the whole platform can move and the environment can move. So this is the most immersive example that you can have. But this is not very practical for daily life physiotherapists, as you can imagine, as this kind of system costs about €3.5 million. Okay. I don't know. Okay. Another interesting development was by Citroën, developing glasses that provided, as you can see, some glasses that have inside of them this fluid that gives you a horizon while you're driving. They made it very fast, a lot of advertisement that this was the solution for car sickness, and you already expect it, it doesn't work. So it's simple, but you can see that many people tried to use all kinds of feedback possibilities to improve spatial intelligence, postural control, whatever. Okay, so what we learned from all these things is that vibrotactile feedback is really efficient and very practical, much more practical than visual and auditory feedback. Because you can take it with you, although it was used predominantly by all the researchers in the past for rehab. So one of the inventors of vibrotactile feedback in the clinic was Konrad Wall, together with Cinco, and they developed a special belt, as you can see, with a lot of tactors, with a sensor. Again, when you're moving and via a computer, you can control the vibration set. So when you move forward, you feel vibration here. When you move backwards, you feel vibration there. So it can help you to improve postural control. Now, this was, of course, something that was used in the lab. And it shows, again, that it works very well. One of the examples of the commercialization of this principle was the VertiCard, also a system where you wear a belt with vibrators in it and a sensor detecting postural movements. And that gives, with 4 tactors, information how you are moving, and that is used for training, as you can see as an example. Became more and more advanced, these kind of devices. It's very useful for training and a device even at home for elderly and even for people with central ataxia. So it works pretty well in many patients. But the most important thing is that vibrotactile feedback that speeds up this rehab. But after you stop doing it, the effect is generally away. So it's useful. In conclusion, when we talk about this type of vibrotactile, so it optimizes rehab, makes it faster and better. It improves motivation. We can use it in gamification. It reduces postural sway in the lab. It improves balance during gait in the lab. But when the rehab is stopped, the effect of the augmented training in daily life decreases very fast in time. And that means that the rehab in this traditional way needs to be continued for a long time. Otherwise, the effect will disappear. Now, what is the problem? Although many people improve with the rehab, there are still also a number of patients that said, okay, yes, but I have to come back all the time, and I don't want to do that. And on the other hand, I'm not even happy with the result. That's not for all patients at all. It's a subpopulation of bilateral vessel loss patients, for example, that say it's nice, this training, but it doesn't reach the level that I want to improve my quality of life to the best level. So you have different patients that have different demands. Okay, so we started in about 2000 with the development of vestibular prosthesis. The vestibular implant, Angelica will talk about that, and of course also the balance belt as a non-invasive alternative. So we did a lot of studies to find out what is the best place of the vibrators. For example, John Allen put the vibration on the head. And we needed to find out, is this really the best solution? The VertiGuard, use it around the waist. And before the VertiGuard, we were already busy with the development of all these things. Okay, so the principle is that you have motion sensors and gravity sensors that via a computer microprocessor translate that motion into stimulation patterns around the body, wherever, and gives you an improved sense of gravity accessibility because you lost that functionality from the balance. And the idea is to re-automatize balance, not to be aware all the time what is going on, because that drives you crazy. You have to feel all the time how you are moving. No, normally we move without thinking about it. Many people even don't know they have balance. Okay, so there are 4 different options. Without going into the details, we evaluated by this the effect of this feedback by looking at posture and looking by gait, and also asking patients what is something that you prefer to do. And the outcome is very simple. When you put the sensor and detectors around the waist, then everybody liked that the most, and we saw the biggest effect on posture and gait. So that made it easy for the design of the device, because everything is around the body. And we made it ambulatory, which means, this is about 15 years ago, you have to have a battery, you have the computer, etc. So I was wearing a vest, and inside the vest were all the supplies and things like that. So it looks very funny, but it worked. And we had a lot of patients trying out this vest. So it looks very sportive, as you can see. Okay. Now, okay, the principle, however, is very simple. And the goal was, of course, to optimize it. And so here you can see you have a number of tactors. In the old concept, we have 12 tactors. And the vibration pattern was controlled by the sensor. Basically, again, when you move forward, you feel vibration here. When you move backward, you feel vibration there, and so on. And when you make a hula hoop like this, you feel that there is a rotation pattern of the vibration. So that is the concept. And you here can see that the prototype that we developed in the university, and with this belt, 10 belts, we could do a number of studies and to see how effective is it and how can we optimize it further. Okay, so we found that the patients generally use it for continuous walking to reduce their sway and stance during gait. And the mission to the patients was, of course, try to use it all the time when you're walking. Very fast, we found out that if you instruct the patient to pay attention to the movement, it becomes a burden. It becomes an extra cognitive task, and things even become more complex. So the challenge is to say to the patient, please don't pay attention to it. Just go walk and see whether you can subconsciously start to use the vibration pattern. Some people have no problems in doing that, and some people have a problem to do that. But that is one of the issues. But okay. So we came then to this really concept of unconscious wearing the belt. So it gives a feeling of touch, a little bit like when you in the night go to the toilet and you don't see anything, and you put your hand on the wall to have a reference so that you know how to walk. And the belt basically is your gravity reference, which walks with you while you're doing all kinds of tasks. It's the same kind of application. So we did a pilot study in which we gave patients different kinds of vibration patterns. We selected them first as responders, so we gave them the correct pattern. And we selected 5 patients with a bad score. I'll come to that in a second. And then we gave them 5 different other patterns and asked them, what is the best for you to control balance? So we just say we try to optimize everything, and you have to pick out the right one. And the score was subjective. We asked them, if you go in daily life for a month walking with this belt,
how does your mobility and balance improve? So we first scored that before the use of the belt. And we asked them, what is your score between 0 and 10 of your mobility and balance? The patients that we select for the belt always have a score that is lower than 5 or less. There are patients with bilateral vascular loss that have a higher score. And then there are two for the application of the belt. If it's 5 or lower, they have a chance to improve. The majority of these patients that we selected had a range of 3, 4, something like that. And then the key question is, how is this score, which means 0 is you hardly can walk, and 10 means your personal best in life before the problem started. How is your score at this moment? So when you have this score 3, 4, you start the experiment, then it's okay. And you'll see that when they are not wearing the belt or have a placebo, you can see that there's a very low score. And when they wear the belt, it's immediately improving. So this was a first indication that the belt is really working properly after the new design. But then we did a study where we simply included 31 patients. So it took a lot of time because we had only 10 belts, etc. And every period was about a month. And we asked them, what is your score before you start to wear the belt at home? And then when you have the real belt for a month, if it's improving. And you can see there's quite a lot of improvement of their scores. We did a follow-up of these patients, was in COVID time, so not so easy. Many people didn't come. We have to have a telephone consult. And you see that in time, even 2 years after inclusion, they were still wearing the belt. So very high adherence. Only 15 patients out of the 89 that were included in the beginning stopped wearing the belt, of which 6 stopped because they died. That is what happens when you have elderly patients.
Not because of the belt.
But I think that is something to be honest. I don't. But I associate that it's pretty safe. Maybe they fall and was picked up. But no, and there were 9 patients that we simply were not able to reach anymore. So, but this is a pretty good result because I think you're always interested in, okay, you have therapy, but are you really going to use that? We know from hearing aids that many of the hearing aids end up in the cover. Okay, so that is improving. What was the improvement in score? And you can see on average, they have about 4 scores, but the minimum is 2. So that means that we consider it as a success when the score is 2 or more. Then you say, okay, it's a helpful thing. That is what the patients also indicate. So when they have an improvement of 2, they say, yes, I'm happy with this belt, etc. So what about gait analysis? You can see the functional gait analysis also improving and holding for quite a long time. So still assessing the rest. So now we have this final belt, and if you want to try it, we took a number of belts with us so we can try it, where you can adjust the sensitivity, you can adjust the intensity of the vibration, so to fine tune it to a specific patient. Okay. Now, so you can use it by switching it on and off, etc. Here you see an example in France. First without belts. This is a group of bilateral vascular loss patients in Paris. It's the Society of Bilateral Vascular Loss, who comes 2 times per year to work, I think, in Paris with Professor Coupe to talk about what we can do about their life. So they tried the belt, and this is when we put the belt on. Of course, we're all scientists. So when you look at this, the key question, of course, how much is placebo, how much is real? And that's why it is interesting to show you that we also try the belt in small children which have a cochlear implant and have additionally a bilateral vestibular loss, a clear bilateral vestibular loss. So this is a child from Toronto without belt, doing a few exercises. For the sake of time, I'm not showing all the experiments, but see, it's quite unstable. For his is already pretty okay, I must say. We have quite a number of patients that are even much worse because they really have a handicap because they cannot play with their friends. This is with the belt, mini belt. So I think this is the emotional end of the balance belt, because you can imagine that everybody becomes very happy when he sees this. And most likely we will start very soon close cooperation with Nobel, I hope. The of the small children with cochlear implants that need also additional treatment for their motoric retardation. So there's a protocol that we develop now in the clinic. So the patient comes in, bilateral vestibular loss, kids who vestibular rehab is not happy enough. And this subpopulation of patients, we ask them, what is your balance and mobility score? If it's lower than 5 or lower, then you say, okay, you can try the belt in the clinic for 2 hours, because many patients immediately in 2 hours can indicate if it's helpful, yes or no. And if they are positive, they get the belt, we try it out for 3 weeks or a month. And then after that, they can decide whether it is a useful device for them, yes or no. Thank you very much.